Urinary incontinence. Urinary incontinence is involuntary or uncontrolled loss of urine from the bladder. There are different types. Stress incontinence is the involuntary loss of urine through intact urethra as a result of sneezing, coughing, changing positions. Common in women who have had vaginal deliveries and men after radical prostatectomy. Urge incontinence is involuntary loss of urine associated with a strong urge to void that cannot be suppressed, seen with neurological dysfunction that impairs inhibition of bladder contraction and in patients without overt neurological dysfunction. Functional incontinence is involuntary loss of urine due to severe cognitive impairment, like Alzheimer's and dementia. It can't identify that they need to void or unable to physically reach the toilet, but the urinary function is intact. Iatrogenic incontinence is involuntary loss of urine due to extrinsic medical factors, predominantly medications like alpha-adrenergic blocking agents for hypertension, keeping bladder neck relaxed, like doxazocin and Cordura, tamsulosin and Flomax. Overflow incontinence is incontinence due to overdistension of the bladder. Mixed urinary incontinence is caused by a combination of the above types. Causes for urinary incontinence include relaxation of the pelvic musculature, disruption of cerebral and nervous system control, and disturbances of bladder musculature. Risk factors include older age, unavailable toilet or caregiver, decreased bladder capacity in older clients, lacks pelvic muscles in females, immobility, chronic degenerative diseases, diabetes mellitus, stroke, medications, morbid obesity, incompetent urethra or sphincter relaxation, bladder or prostate surgeries. Therapeutic management includes measuring post-voiding residual urine. Treatment includes surgery, lifting and stabilizing the bladder or urethra, creation of artificial urinary sphincter, TURP or transurethral resection of the prostate for patients with BPH. Medications include anticholinergics like oxybutynin or ditropan and tricyclic antidepressant medication, amitriptyline or Elavil, for stress incontinence by inhibiting bladder contraction. Behavioral therapy includes Kegel exercises, that is, trying to stop and start the stream of urine, limiting fluids such as caffeine, colas, alcohol, or other bladder irritants, voiding before bedtime and upon arising from bed, voiding at predetermined frequencies like every 2 hours or every 3 hours, avoiding diuretics after 4 p.m., avoiding smoking to prevent frequent coughing, and avoid constipation by drinking adequate fluids, consuming a diet high in fiber, exercising, and using stool softeners if recommended. Patient education. Urinary incontinence is not inevitable and is treatable, meaning all old people are not incontinent. Management takes time. Provide encouragement and support continuously. Education must be given verbally and in writing. Develop and use a voiding log or diary. Behavioral interventions may be used. Medication education related to the different drugs they're taking. Care of intermittent catheterization at home if required. Recognizing and reporting the signs of UTI, like burning micturition, cloudy urine, fever, pelvic pain, and strong urine odor or malodorous. Moderate to high fluid intake and a diet that acidifies the urine, like cranberry juice and vitamin C, 1 gram daily. Wear clothing that is easily removed for ease in toileting. Use assistive devices such as raised toilet seats, bedside commode, and urinal or bedpan as needed. If depends are used, teach regarding skin care and avoid moisture to prevent skin breakdown. Urinary retention. This is the inability of the bladder to empty completely. Residual urine is the amount of urine left in the bladder after voiding. In older adults, an amount equal to 50 to 100 ml is considered normal. Causes for urinary retention include post-op under general anesthesia, diabetes, BPH, renal calculi, pregnancy, neurological disorders, spinal cord injury, medications, removal of investment of the bladder. The bladder will be firm and distended, displaced to one side of the midline. Management includes surgical correction, monitoring the eyes and nose accurately, stimulate the relaxation of urethra by providing privacy, appropriate positioning, sitz bath, warm compress to the perineum, hot showers, placing the hand in warm water, turning on the water faucet. Intermittent catheterization is also done to help with urinary retention. Avoid medications that cause urinary retention. Complications include chronic infections, predisposing to renal calculi, pyelonephritis, sepsis, and hydronephrosis. Renal calculi can be either urolithiasis or nephrolithiasis. Client teaching for urinary retention include teaching the client how to perform intermittent straight cath at home if necessary, recognizing signs and symptoms of UTI, drink moderate to high amounts of fluids, and a diet that acidifies the urine. Cranberry juice and vitamin C helps to maintain acidity to prevent UTI. Teach the uses and side effects of prescribed medications. Modify home environment for easy, safe access to bathroom. Install support bars in the bathroom. Place bedside commode and urinal within reach. Wear clothes that are easily removable and keep a light on in the bathroom at night. Urolithiasis and nephrolithiasis. Urolithiasis and nephrolithiasis refer to calculi or stones in the urinary tract and kidney. The types of stones are calcium phosphate, calcium oxalate, which is the most common, uric acid, and struvite. Struvite is caused by bacterial infection in the urinary tract. Ammonia is produced during the formation of these stones, and so the urinary pH is above 7. And cystine stones. The risk factors for calculi are family history, dehydration, which results in supersaturation of the calculus-forming substances, urinary stasis, immobility, infection or obstruction, metabolic factors like hyperparathyroidism, renal tubular acidosis, cancers, elevated uric acid levels as in gout, dietary factors like high in vitamin D or calcium, purines, oxalates, protein or alkali, example milk. Defective oxalate or uric acid metabolism. UTI causes struvite stones. Clinical manifestations. Signs and symptoms of stones in the urinary system depend on the presence of obstruction, infection, and edema. Urethral stones causes renal colic on the affected site that is acute, sharp, excruciating wave-like pain that radiates down the thigh and to the genitalia. Renal pelvis stones is associated with intense deep pain in the costovertebral region, hematuria, pyuria, and the pain radiates anteriorly downward towards the bladder in the female and towards the testis in the males. Other signs and symptoms include nausea, vomiting, pallor, diaphoresis, diarrhea, and abdominal discomfort. Diagnosis is mainly by 24-hour urine levels of calcium, uric acid, or oxalates, pH, renal function test, non-contrast CT scan, chemical analysis of the stones if passed or extracted. And for this purpose, strain all the urine and save the stones. Therapeutic management. The goal of management is to eradicate the stone, determine the type, prevent nephron damage, control infection, and relieve obstruction if present. Relieve pain with opioids, NSAIDs, hot baths, and moist heat to flank area. Fluids are encouraged but not forced. Generally, stones that are 0.5 to 1 centimeter in diameter are passed by the patient through urination. If larger multiple stones, obstructing stones, like for example staghorn calculi, require surgery, strain all urine and save stones for analysis. Provide pain relief measures and treat other symptoms as they occur. Opioid analgesics and NSAIDs are effective. Assess urinary function lab results like BUN creatinine, GFR, electrolytes, hemoglobin, and monitor the eye's intake and output. Encourage ambulation to prevent resorption of calcium from the bones. Fluid intake, daily weight. Unless contraindicated, patients with kidney stones should drink 8 to 10 8-ounce glasses of water daily and have IV fluids prescribed to keep the urine dilute. Urine output exceeding 2 liters per day is advisable. Medications. Antimicrobials, analgesics, antiemetics, diuretics are administered to prevent urinary stasis. Dietary management according to the type of stones. Calcium phosphate stones limit high calcium foods, acidify urine with acid ash foods. Calcium oxalate stones limit the oxalate foods, acidify urine with acid ash foods. Struvite stones acidify urine with acid ash foods. Uric acid and cysteine stones alkalinize the urine with alkaline ash foods. Avoid purine foods, low protein diet. Acid ash foods include cranberries, grapes, plums, prunes, tomatoes, eggs, cheese, whole grains, meat, and poultry. Alkaline ash foods include legumes, milk, and green vegetables. High calcium foods include milk and other dairy products, beans and lentils, and fish. High oxalate foods include spinach, strawberries, peanuts, tea, and wheat bran. High purine foods include shellfish, organ meats, and mushrooms. Client teaching. Dietary alteration according to the type of stones is taught to the patient. Adequate fluids, exercise, report signs and symptoms of infection, complete medication, prevent UTI and regular follow-up, recognize recurrence and complications. Limit sodium intake to 3 to 4 grams per day as sodium competes with calcium for reabsorption in the kidneys. Low calcium diets are not generally recommended, except for true absorptive hypercalciuria, as it can lead to osteoporosis, especially in women, and does not prevent stone formation. Avoid dehydration and sweating by avoiding sudden changes in environmental temperature. Contact primary care provider for signs of infection, burning with urination, cloudy urine, or fever. Report increased pain, persistent blood in urine, inability to void, significant decrease in urine output. Complete the course of antimicrobials and monitor for any side effects. Interventional procedures for urinary stones. First is ureteroscopy. This is use of a laser electrohydraulic lithotripter or ultrasound to fragment and